Morning everyone. Case number 6. History given to us was section from medium sized muscular arteries. In this image we can see small to medium sized vessels surrounding which are mixed inflammatory cell infiltrates composed of lymphocytes, eosinophils and neutrophils along with fibrinoid degeneration of vessel wall. So the diagnosis was polyarteritis nodosa. Coming to review of literature, polyarteritis nodosa is a systematic vasculitis of small or medium sized muscular arteries, but not arterioles, capillaries or venues, typically involving renal and visceral vessels but sparing the pulmonary circulation. About 30% of patients with PAN have chronic hepatitis B with hepatitis B antigen antibody complexes in affected vessels, indicating an immune complex mediated etiology in that subset. Clinical manifestation result from ischemia and infraction of affected tissues and organs. This is the diagrammatic representation of various types of vasculitis. Examples of large vessel vasculitis are giant cell arteritis and Takayasu arteritis, which are granulomatous diseases. Medium vessel vasculitis are immune complex mediated polyarteritis nodosa and Kawasaki disease, which is mediated by anti-endothelial cell antibodies. Small vessel vasculitis is further classified into immune complex mediated and anti-neutrophilic cytoplasmic antibody related vasculitis. Immune complex mediated vasculitis are SLE, Henoch-Schellin purpura, cryoglobin vasculitis and Goodpasture disease. Clinical features: though typically a disease of young adults, polyarteritis nodosa can occur in pediatric and geriatric populations. The course may be acute, subacute or chronic and is frequently remitting and episodic with long symptom free intervals. Because the vascular involvement is widely scattered, the clinical signs and symptoms of PAN may be varied, puzzling and not always referred to as vascular sores. The most common manifestations are malaise, fever and weight loss. Hypertension usually developing rapidly due to renal involvement. Abdominal pain and melena due to vascular lesions in the gastrointestinal tract. Diffuse muscular ache and pain and peripheral neuritis. Renal arterial involvement is often prominent and a major cause of death. Classic PAN is characterized by segmental transmural necrotizing inflammation of small to medium sized arteries. Vessels of kidney, heart, liver and gastrointestinal tract are involved in the descending order of the frequency. Lesions usually affect only part of vessel circumference and show a predilection for branch points. The inflammatory process weakens the arterial wall and can lead to aneurysm and even rupture. Impaired perfusion resulting in ulceration, infarcts, ischemic atrophy or hemorrhage in the distribution of affected vessel may be the first sign of the disease. Microscopy: during the acute phase, there is transmural inflammation of arterial wall with a mixed infiltrate of neutrophil, eosinophil and mononuclear cells, frequently accompanied by fibrinoid necrosis. Luminal thrombosis can occur. Later, the acute inflammatory infiltrate is replaced by fibrous thickening of vessel wall that can extend into adventitia. Characteristically, all stages of activity coexist in different vessels or even within the same vessel, suggesting ongoing and recurrent insults. This is the image showing polyarteritis nodosa. We can see here a small sized artery surrounding which we can see inflammatory infiltrate and fibrinoid necrosis and thrombotic occlusion of the lumen. Coming to differential diagnosis, In the differential diagnosis of polyarteritis nodosa, there are different types of vasculitis which are necessary to be ruled out from each other. First one is large vessel vasculitis, giant cell arteritis and Takayasu arteritis. Giant cell arteritis is a granulomatous inflammation, frequently involves the temporal artery, usually occurs in the patients older than age 50 and is associated with polymyalgia rheumatica. Takayasu arteritis, granulomatous inflammation usually occurring in patients younger than age 50. Coming to medium vessel vasculitis, these are polyarteritis nodosa and Kawasaki disease. As we have seen, polyarteritis nodosa is a necrotizing inflammation typically involving renal arteries but sparing pulmonary vessels. Kawasaki disease shows arteritis with mucocutaneous lymph node syndrome, usually occurs in children. Coronary arteries can be involved with aneurysm formation and thrombosis. Small vessel vasculitis, these are Wegener granulomatosis, Church-Strauss syndrome and microscopic polyangiitis. Wegener granulomatosis shows granulomatous inflammation involving the respiratory tract and necrotizing vasculitis affecting small vessels including glomerular vessels. Church-Strauss syndrome, it is a eosinophil rich granulomatous inflammatory condition involving the respiratory tract and necrotizing vasculitis affecting small vessels. Microscopic polyangiitis, it shows necrotizing small vessel vasculitis with few or no immune deposits. Thank you.